because I had some last
Yes,
minute issues with my laptop, so I've logged in from an old one, so I don't know.
it's all fine, Sreedevi. We can
Yeah.
hear you well. Go ahead.
Yeah. So Sangeeta, I'll start sharing my screen. If there is anything stuck in between, you can take over the screen.
Okay, sure.
Okay. Thank you. So as Madam told, we are all in the midway through the program. You might have heard a lot about gastrointestinal symptoms last week, specifically on nausea, vomiting, and constipation, which is very, very commonly seen. I must say, even if pain is something that we focus on in palliative care in terms of symptoms, constipation is the most common symptom that we come across invariably across patients. Whatever their diagnosis is, whether it is cancer, non-cancer, constipation is something that you will come across, followed by nausea, vomiting. And today we will be talking mostly about the bowel obstruction and specifically malignant bowel obstruction because there are so many types of bowel obstruction. We may not be able to cover everything, but we'll focus on the malignant bowel obstruction because that is one of the most common symptoms that we will come across in palliative care. Yeah. So this is the working definition of malignant bowel obstruction. It is that anything which shows the signs and symptoms with a radiographic evidence and whichever is causing any obstruction in the transit of GI content. So anything which is causing an obstruction and which is showing signs and symptoms of bowel obstruction plus a radiographic evidence is what they say as a working definition of malignant bowel obstruction. It can be directly due to cancer or it can be due to the treatment that the patients take for cancer. So we'll come across. So one of the very important thing to understand in managing bowel obstruction is that we can't create one algorithm everyone can follow in managing bowel obstruction. For example, nausea and vomiting, we know that which drug will help in which type of vomiting. Bowel obstruction is a little difficult to manage. Each patient needs a tailored plan, or it is not as simple as that we talk like in pain ladder, 1, 2, 3. We can't create such a step ladder or a flow chart in managing bowel obstruction because there is a considerable variation in symptoms. Each patient will have different kind of symptoms, different kinds of issues that they come to you, and the approach to management is also varied from patient to patient. And generally, when someone present with malignant bowel obstruction in a palliative care setting, mostly they will be in the very advanced stage of cancer. But if you're working in a gastro OP or a surgery OP, bowel obstruction can be the first sign of any gastric cancer or any GI cancer. But when it comes to palliative care, generally bowel obstruction is not something that is having a good prognosis. They are coming to, we know that, okay, this patient might be in the advanced stages. Can someone say which is the most common cancer which can cause bowel obstruction? What is the most common site of cancer will be presented as, or there's a chance that you can see bowel obstruction as one of the complications. The most common cancer associated with MBO. I'll wait for some response in the chat or you can unmute and talk. Dr. Neeta is telling esophageal cancer. Any other response? Rectum, colon, CA colon, rectal colon. So it's mostly the GI cancers which are coming up. Thank you so much for the response. So we must know because then we will be prepared when we see such a patient with that diagnosis. So generally, the median survival when they present with malignant bowel obstruction is very less. So when you see a patient with malignant bowel obstruction, you can say that safely that the patient's survival might be anywhere from 1 to 3 months or very short number of months. And in terms of site, It can occur anywhere. So both sites you have mentioned in the chat, someone mentioned esophagus, a lot of people mentioned rectum. So it can occur anywhere from esophagus to rectum. And the most common site among the GI tract is small bowel. The most common site where the obstruction can happen is small bowel. My question was, which cancer will cause most amount of malignant bowel obstruction? It is largely gynecological cancer, mainly ovarian cancers, followed by colon cancer. I could see a lot of response on colon cancer, which is right, but it is slightly predominated by the gynecological cancer. If you think about the patients that you might have seen, patients with CA ovary mostly come across with a huge amount of bowel obstruction, ascites, and other complications. That is most common, followed by colon cancer. But we see malignant bowel obstructions in other cancers also, like in breast or gastric or the lung and the pancreas, probably not due to the primary cancer, but due to the distant metastasis, which can happen. So evidence says the breast, gastric, lung, and pancreatic cancers can also present as malignant bowel obstruction. So remember, few things from this slide. The prognosis is very bad. The median survival will be very less by the time they present with malignant bowel obstruction. And the most common cancer associated with bowel obstruction will be gynecological cancers, followed by colon. And the most common site is small bowel. So these are the few important things that we need to remember from this. There are different types of bowel obstruction. I'm not going into detail by detail or definition, but from the name itself, which is very evident, it can be mechanical or functional. Mechanical can be due to a tumor mass. Functional can be due to a nerve paralysis or due to your drugs. That I'll tell you. For example, if you say when you give morphine, it can reduce the bowel activity. It can mimic symptoms like bowel obstruction. Although there may not be a evident cancer mass obstructing the GI tract. It can be a partial obstruction so that the other contents will pass through the whichever gap is remaining, or it can be complete obstruction. It is self-explanatory. That's why I'm not going into the details. Single site or multiple sites. In this single site, better chance for other management strategies. Multiple sites, the chances for treatment are very, very limited. And when the tumor is causing a mechanical obstruction, it can be through the intraluminal or an intramural obstruction. Or sometimes, as I said, in CA ovary, the cancer mass is not inside the GI tract, but the obstruction can happen from the outside. The tumor mass is outside the bowel and it causes obstruction from the outside, which is called as extrinsic obstruction. So these are just terms that we should understand. When you come to clinical practice, I don't think we may be thinking.
Sreedevi, someone
Yes.
has raised their hand. 1 minute.
Sure,
Sangeet,
sure.
I think, can you just check, Sangeet? I just saw someone's hand raised.
Sorry, I didn't.
Subhada, I think. Dr.
Yes,
Subha.
yes, Sangeet. Can they unmute and ask if you have any query? Or
I think she put the hand raised instead of attendance because of attendance.
Oh, yeah.
Okay. Thank you. Sorry, Sreedevi. Go ahead then.
No problem.
Just wanted to make sure.
No problem. So, as I said, there can be functional obstructions, adhesions. When they undergo complicated surgeries, there can be adhesions which can cause obstruction. Sometimes there can be desmoplastic reactions to the chemotherapy that they are going through, which can also mimic all the symptoms of obstruction. There can be torsions or internal hernia. So it can be treatment related. Or very rarely, what happens is that there is a pseudo obstruction. There can be, for example, there can be a lesion which is destroying the enteric neurons so that the nerve signals are not reaching the bowel properly. So it will mimic all the symptoms and signs and symptoms of obstruction, but it is a pseudo obstruction because of the destruction of neurons, not due to the obstruction by the mass itself. There can be, as I said, drugs like morphine can cause, or some of the chemotherapeutic agents can cause severe EBS. One typical example, which we never think of which I never thought of till we had a patient with diabetic neuropathy, that she came up with all the signs and symptoms of bowel obstruction. She had all the, so we were wondering whether there is something that we are missing out. We went through intense investigations. She was sent to gastro department. All the scans were done. Then we realized it is due to the diabetes, not due to any cancer, which had caused, which is not very common, but that is one thing that you need to rule out when you are treating bowel obstruction. I'll just touch upon the pathophysiology so that it is easy to relate when you come to symptoms, that why it is happening. So whenever there is an obstruction, so imagine there is a tube, there is an obstruction in the tube. So what happens when there is obstruction? There is fluid buildup. Your GI tract is continuously secreting gastric, biliary, and pancreatic secretions from various sites. So whenever there is obstruction, for example, when you have something in your throat, then you salivate more. So whenever there is an obstruction, there is a reaction which comes as more and more secretions. And whenever there is an obstruction, the secretion, the reabsorption will be reduced beyond the site of obstruction. Usually, we know that there are sites in GI tract which will cause reabsorption of water and sodium. This will be reduced, and there will be more and more secretions happen. So what happens when there is more and more secretion? So in a tube, more and more water is being produced and there is a block. The tube, if suppose the tube is flexible, if it is expanding, a silicone tube, it will start expanding, right? So there is more distension. Whenever there is more distension, the patient will come and tell you, I have bloating, I have pain, I have nausea and vomiting. So it is kind of like a cycle. More the secretions, the more will be the distension, more will be obstruction. And whenever there is obstruction, there will be more secretion. So it just happens like a cycle. That is how the pathophysiology progresses to a complicated obstruction. So these are some of the consequences if we do not treat bowel obstruction. Maybe sometimes even with treatment, there is always a chance of hypovolemia because there is a large amount of fluid being secreted into the GI tract and there will be hypovolemia. The reabsorption is reduced, which can cause renal failure. And there will be a lot of metabolic imbalances like alkalosis, acidosis can happen. And imagine you are breathing through your diaphragmatic movement. So whenever there is a distension, the diaphragm is pushed upwards, right? So the patient will be having difficulty in breathing, which is due to decreased pulmonary ventilation. So at later stages of bowel obstruction, your patient might tell you that I can't breathe because of the obstruction, because of the distension, the diaphragm is pushed upwards, so they can't breathe properly. And over a period of time, there will be seepage of toxins and even the intestinal contents into the lymphatics. So at later stages, the patient will literally present to you with septicemia, with all the hypovolemia, the changes in temperature, decreased response. So all this will come at the later stages of bowel obstruction. So there can be metabolic consequences, there can be septic consequences. You can stop me at any point if there is any doubt regarding this. So we will move on to the next, very, very important. So many of us are not working in a system or a place where you can send patients for CT scan every now and then to understand where the obstruction is. Because our treatment should also depend on where, how much, or how intense, etc. So this is one simple thing that you can remember. Whenever the obstruction is at a higher level, there can be more symptoms. Whenever the obstruction is at a very lower level, the symptoms will be less. So I'll tell you a very simple example, which I learned. So few years back, Robert Wycross is supposed to be, we are all considering him as the founder of modern palliative, after Cicely Saunders, of course. He is one of the best teachers in the world who taught Dr. Rajgopal. He has written a book which you will find in the resource materials, which is Introduction to Palliative Care by Robert Wycross. So that was the first book which I've ever read so passionately from page to page. So when he visited Pallium a few years back, we had a patient with bowel obstruction and he's an amazing teacher. So he was explaining this to the patient why she is having this symptom. So I learned from that and I find it very, very useful. So whenever I see patients with bowel obstruction, this is what I think. So imagine you have a wash basin at your home. Okay. So there is a block in your wash basin. Imagine the block is at the entry level, at the top. Something is stuck at the top of the outlet. What happens when you start washing your hands? The fluid will not go down, right? Immediately after washing, you can see a lot of fluid which is not going down. And the fluid or whatever you are seeing is fresh, not because you just washed your hands. It is a fresh fluid with some particles from your hand, whatever, lot of water. The volume will be more because it is not going down. Imagine the block is somewhere down on the pipe, away from the outlet. It is down the end of the tube. So what happens? You can keep washing your hands in the morning. There is no sign of fluid coming up, right? You wash in the afternoon. You wash at night, you can see a little bit of fluid is coming up because then you realize, okay, there is some block somewhere. And the fluid will not be of large volume. You will see a little bit of fluid coming up. Generally, it will be foul smelling because we have been washing your hands and spitting into it from morning, right? This is exactly the same with the bowel obstruction. When the obstruction is right at the gastric outlet, when the patient starts eating or drinking, they will vomit immediately. So relate that to this. The moment they start eating or drinking, lot of high volume vomiters will come immediately after intake. But when the obstruction is at a very lower level, generally, I don't know how many of you have heard this, patients will say, I had no issues with my breakfast or lunch. There is something wrong with my dinner because as soon as I had my dinner, I started vomiting. Why? Because the obstruction is at a very lower level. They could eat in the morning, sip by sip, everything was fine. But as soon as they had their dinner, lot of accumulation has happened and they vomit. And the nature of the vomiters is also very similar to the wash basin block, which I told. So the signs and symptoms depend on the site of obstruction. So without having lot of investigations at your place, if you are seeing this patient in a home who cannot go and take an X-ray even, these are the things which you can keep in mind to understand whether it is a high level obstruction or a low level obstruction. So again, as I said, in the gastric outlet obstruction, the vomiting and nausea will be early and severe. So the patient will vomit as soon as they take something, and it is severe, with lot of volume. What happens in small bowel? You can imagine when the wash basin is blocked at a very lower level, you can hear some noises after some time, right? Because there is bacteria buildup will be there by night, and when you start washing hands, there can be some noise when the water is passing down. The same thing, more cramps for the patients, more distension, more cramping with nausea and vomiting, but the nausea and the vomiters will be very different. So in large bowel, when the obstruction is lower, symptoms appear later, not immediate. And there will be considerable distension because it happens over a period of time, longer time, and there will be a bacterial overgrowth. So sometimes they present to you as a seepage, like more like a spurious diarrhea because of the bacterial overgrowth. Is it clear till now? You can show a thumbs up or something if there is if it is clear, then I can go forward. Otherwise, we can clarify. Yeah, I can see a few yes. Yes, thank you. So I think some of you have understood. So this is how we differentiate high level obstruction and a low level obstruction. So what is the difference? So now we saw when the symptoms appear. Symptoms appear immediate when it is higher, later when it is lower. And the vomitus is high volume and otherwise it is low volume. Pain can be of two types. There can be a continuous pain sometimes, and there can be a crampiform, intermittent crampiform pain. So sometimes patients say, I have slight amount of pain all the time. Sometimes they may say immediately after meals or having few sips of water, I have severe cramps happening. So these are the two types of pain that we commonly come across. What is the difference in the vomiters? It is sometimes patients vomit fecal matter. In case of lower level severe obstruction, we have instances where patients will vomit their own fecal matter, and it is very, very distressing. No one wants to have that in their life. It is very important to manage as early as possible. In the outlet obstruction, when the obstruction is at a higher level, it can be biliary vomitus. It is more or less of slight greenish color or yellowish, like a normal vomitus, large volume. But in lower level, it can be feculent. What about constipation? In complete obstruction, so one thing is that it is a very important question that you should ask every patient when they say that I am not passing stools. Are you passing able to pass plates? Are you passing gas? So they say no. I want to pass some gas, but I am unable to. That is one important indicator that it can be a complete obstruction. Even the gas is not passing through the tube. So that is so the management is different when it is complete obstruction. And always auscultate to check the bowel sounds. Sometimes above the obstruction, you can hear a lot of increased bowel sounds. Sometimes there is decreased bowel sound. So all of this indicates the level of obstruction, how partial or complete it is. I've made a table. This is very easier to understand when it comes to patient. You can just refer to the symptom. In terms of pain, if it is an upper level obstruction, symptoms will be earlier. There can be cramps and there can be peri-umbilical pain, the pain around the umbilical area. If it is distal, symptoms will be very, very late and there will be long intervals between the cramp. You can imagine it has to reach the tube down. It will take some time for the cramp to develop. It is not as high as the gastric outlet. And in gastric outlet obstruction, there will be large amount of bobbitures. There won't be, so it's like a wash basin, fresh block. No foul odor, it is more watery. When the block is down, small amount of particulate, foul odor. Usually, when it is a proximal obstruction, there won't be much of a distension. The tube of the wash basin will be absolutely fine because the block is somewhere up. But if the block is somewhere down, there can be a distension of a abdomen. Constipation may or may not be present in proximal obstruction, but in distal obstruction, constipation can be weeks long. So I'll move on to the evaluation. It is rarely an emergency. As I said, some of the cancers, we know that this can come up with a presentation of bowel obstruction. Very rarely they come to an emergency department telling that, oh, I suddenly developed bowel obstruction from today morning. That may not happen. They start with slight pain, nausea, vomiting. So we should be able to identify it as early as possible. And how will we decide on the treatment? We have to evaluate their overall status, at what stage of illness trajectory they are. Are they coming up with the symptom for the first time, or they have been having this bowel obstruction symptoms for quite a long time, whether the survival is less. So depending on that, we have to come up with a treatment plan. And the important thing, the focus is not to remove the obstruction surgically. The focus is to reduce the pain, nausea, vomiting, and fluid status. It is not about removing the tumor mass so that your block is removed. No. Our aim should be to address the symptoms. Very rarely we go for investigations, but mostly electrolytes and hydration, but that is very, very rare. This is an example of an abdominal radiograph, and this is the altered air fluid level in the radiograph. You can see multiple air levels in this. This is one of the clear radiograph which I got from internet. You won't see this clear radiograph in bowel obstruction when you see patients, but you can actually see multiple air fluid levels when you take an X-ray erect abdomen, not lying down. I've recently come across a doctor sent a patient with lying down X-ray, but that will not give you any clue. It has to be X-ray erect abdomen. Sorry. So this is one of the most investigation that we can try because it is easily available, not that expensive. In that we can, if it is a distal obstruction, we can see multiple bowel loops, air fluid levels very clearly, like few levels. But again, sensitivity is less than 50%. You can rely on X-rays as an investigation. So this is the two these things in supine you will not see it very clearly. It has to be X-ray rectangle. This is the 100% most useful test is CT scan. So when you do a CT scan, you will know whether there is a single obstruction, multiple, what is the nature of the obstruction, what is the nature of the surrounding circulation, whether it is malignant, all these can be ruled out or can be understood from a CT scan than from an X-ray. But very, very, I've not done, I don't think anyone do a CT scan because when it comes to palliative care and with the progressive malignant bowel obstruction. Um, so we'll come to the management part. Very, very important is oral care because the patient will be vomiting continuously. They will be dehydrated. So what we see is that they will have a very bad oral hygiene, foul smells, dry mouth, and ultimately leading to a lot of candidiasis. And because of all the attention going through the vomiting and nausea, the mouth care should not be ignored. Tell them to suck ice popsicles if possible and small amount of fluids just to wet their oral cavity. And if the patient is not is dehydrated, very badly dehydrated and not dying, we can think of IV hydration, but we generally don't go for IV hydration when someone with malignant bowel obstruction. We can always rely on some subcutaneous fluid to maintain hydration. Again, very important thing. We should choose the route of administration. Now they are unable to swallow. They keep vomiting whenever they swallow something. So we cannot give tablets, right? Oral medications will become impossible. So choose the route of administration. So the first thing is to reduce the pain. How will we reduce the pain? We can use opioids. But how will we use opioids? They can't swallow. So we have to choose whether it is subcutaneous or IV or rectal or patches or whatever, but not oral. So opioids. Sometimes we use antispasmodics to reduce the cramps, which I'll come to the dose again. So again, imagine that there is a traffic block. There is a narrow road and there is a traffic block. The vehicles are like spread over from everywhere. So what we try to do is to reduce the traffic block by letting small scooter and cycle to pass through the block, right? That is what we do. From the one side, the police will tell, okay, the scooters, you go ahead so that there is some space. Something similar we do. We try to give steroids as the first line. What steroids will do? The steroids, the steroids will reduce the bowel wall edema. So whenever there is a cancer, whenever there is a tumor, there is something called peritumor edema. There will be edema surrounding the tumor. So our intention is to reduce the peritumor edema by giving steroids. So when you reduce the peritumor edema, you may get a small gap in the bowel, very small gap. So some sips of fluid and food can pass through that very small gap there. You are literally trying to manipulate the traffic block there by giving steroid. So we give steroid for 3 days. If the patient is not responding, we stop the steroid because if it is not helping the patient, prolonged use of steroid can cause other complications. So we do a 3-day trial. The dose can vary from 8 to 16 milligrams subcutaneous. It is the preferred choice of steroid is dexamethasone, and we should give it once daily dose, not BD, TID. No, absolutely not. If anyone is interested, you should go and see the duration of action for dexamethasone. So it is once daily dose of dexamethasone to reduce the bowel wall edema. So we reduce the bowel wall edema. Now there is a narrow gap. Imagine that you have created a narrow passage. There is a gap. Now you want to stimulate the gut motility. Whatever contents are there should pass through whatever gap is available. For that, we give a prokinetic. The prokinetic, preferred prokinetic is, you might have heard in nausea, vomiting, a D2 receptor antagonist, metoclopramide. The dose can vary anywhere from 30 milligram to 120 milligram per day. Generally, we start with 10 milligram 3 times. One important thing is that once you give a prokinetic, after an hour, we should ask the patient whether you have increased pain. So imagine the obstruction was complete, total block, and you give a drug like metoclopramide to increase the motility. It will end up in perforation because there is a mass completely obstructing the GI tract. You give something to push through the tumor mass, it can cause perforation. So it is very important to ask after giving prokinetic, after an hour, ask whether the pain is increasing. You cannot give metoclopramide when the patient is having a complete obstruction. So two things we did three things. We managed the pain by giving opioids. Then we gave steroids to reduce the peritumor edema and create some gap so that we can push some contents across. To push the content, we gave a prokinetic, which is metoclopramide. If it is a complete obstruction, we should shift the focus. Now if we think that it is a complete obstruction, now we can't think about creating a space, pushing the contents. That will not happen. The focus is only for pain management and reduce the vomiting. So there are certain drugs which can reduce the intestinal secretions. The primary drug is a antispasmodic drug, which is hyoscine butyl bromide. You might have heard about Buscopan, which is very commonly used when you have a tummy cramps, when you go to an emergency, which is very commonly used. So that is an antispasmodic drug, which will reduce the motility and secretions as well. The second drug is a ranitidine, which is an H1 antihistamine blockers. We can give up to 200 milligram per day. Sometimes ranitidine can be given as continuous infusion, 200 milligram over 24 hours. The third one is a very commonly used drug in a surgical ward, probably, is the octreotide. So octreotide is a somatostatin analog, which will reduce the secretion. So it has a lot of action. It will reduce the secretion, it will reduce the cramp, it will thereby reduce the pain, and there is a change shift in the splanchnic circulation. It is used only if there is a high volume vomitus. The only challenge in using octreotide is that it's a very, very expensive drug. Mostly patients cannot afford octreotide, and octreotide should be given in pretty high doses and as a continuous infusion, not intermittent dose. So 1 or 2 days, their account will be emptied because it is a very expensive drug. So again, you can think, should we think about expenses all the time? But when you go back to the evidence, octreotide, the effect of octreotide is comparable to placebo or even steroid. So it is okay to avoid octreotide and rely upon steroid. But sometimes, so I have used octreotide in one patient very successfully, is that he was awaiting surgery 2 days later, and he was having a lot of watery, high volume vomitus. Because he's awaiting a surgery after 2 days, which is a corrective surgery, we had to reduce the amount of vomitus that is coming out. So that time, octreotide, we had to go up to 1,200 microgram per day as a continuous subcutaneous infusion, but it worked. But other experiences were not as comparable to dexamethasone, and that is what evidence says, not just my experience. Again, for nausea, vomiting, because the obstruction is complete, you cannot give metoclopramide. In partial obstruction, you can give metoclopramide, but in complete obstruction, you cannot give metoclopramide. That time we can rely upon haloperidol or sometimes promethazine. Generally, they respond to haloperidol really well. So how will we manage? So now we talked about pain management, distension, nausea, vomiting. Now coming to the constipation part. We have to be little gentle when it is a complete obstruction. You can't expect the bowel contents to come out all the time. We have to be very careful when you are giving a stimulant laxative because it can cause more pain because of the stimulation. It is always better to use gentle rectal measures than giving some medication to increase the motility. Again, there will be a lot of questions. Why can't we send them for surgery? Right? There is an obstruction. Why can't we just remove the tumor mass which is causing the obstruction? So generally, it is indicated for single site obstruction. If there are multiple sites of obstruction, they won't encourage surgery in by and large. And if there are additions, a lot of additions, then surgery may not be a good option. And sometimes they do palliative surgeries. Again, palliative surgeries they do just to relieve the obstruction, not to treat it completely. The goal will be to improve the quality of life. Another thing, everyone asks you when there is a bowel obstruction, why can't we put an NG tube and take out all the contents? What do you think? Anyone who has managed bowel obstruction in your setting, what do you think about putting a rice tube and uh, take all the secretions out? When should we consider an NG tube insertion in a bowel obstruction, and how effective it is going to be? I'm sure you might have seen one patient or the other with bowel obstruction, and caregivers asking for either feeding or the surgeon will tell, okay, let's put in the rice tube. Yes, Dr. Zahir, right. Right, Dr. Gauri. Acute obstruction to relieve the distension. Not all bowel obstructions are relieved by RT tube, and it is again depending on the drainage. Wonderful. Yes. So, but invariably, everyone we have seen. Okay, why don't you put in an NG tube? So this is something that we should know. Not all the obstructions can be relieved. Generally, it is useful if the obstruction is proximal, and we have to tell the family that it can be a temporary measure. If your intention is to vent all the secretions out, then NG tube is very useful because it reduces the buildup, fluid buildup, it decreases the vomiting. So we had a patient who had complete bowel obstruction. He was craving to eat. He wanted to taste food, not through the rice tube. He wanted to have biryani once, and he knew that he all the diagnosis he's going to vomit, about obstruction, everything he knew. So what he do is that whatever things he would like to have, he will have through the mouth, and he knows that after some time he's going to vomit. Then he aspirate through the. Then he opened the tube and went it outside. So there was a euro bag which we connected the tube to, so that the secretions will get collected in the euro bag. So the bag that you keep for the catheterization, right, the euro bag, we connected it to the NG tube. So he eats and there is a fluid buildup and it drains out. So he was literally happy because I can taste something through my mouth. He knows that it is not a permanent measure or something, but he was happy that he died in a few days, but he was very, very excited to have that biryani. He could chew, he could eat, and he knows that he's going to start having pain and vomiting. Immediately, he opens that, connect the bag, and this secretions will go out. So these are ways by which people make sure that they are, and we make sure that they are happy and they get what they want when they are having a bad prognosis. Again, about interventions, I'm not reading the whole stuff, but I'll just touch upon that because sometimes we ask ourselves, should we do something more? Another option is venting gastrostomy. Generally, it is indicated for patients who are unresponsive to medical management. But again, it is dependent on the performance status uh, and how bad the adhesions are, how bad the obstruction, the site of the tumor, how diffuse the carcinomatosis process is, whether they have ascites. Ascites, again, we can't do this venting gastrotomy. So this is again depending on various factors. Stent is a very common intervention that people go through when they have bowel obstruction, but the failure rates are very, very high. When you look at the evidence for stents, invariably the failure rates are very high. It is useful if it is a single site obstruction. Again, it will reduce the edema and relieve the obstruction, but it is not the answer for all the bowel obstruction that we come across. Total parenteral nutrition, very controversial because everyone thinks that through your TPN, the patient is going to get all the nutrients they want and they are going to get all the energy back. Very wrong information. At this stage of bowel obstruction, people will not be able to process whatever you are giving through the TPN. And ultimately, what uh, it is uh, it is indicated in patients with minimal tuber burden. And suppose they are waiting for a surgery, they are waiting for a definitive surgery, good performance status, then you can consider total parenteral nutrition. Uh, Only in patients with longer life expectancy, but not in a patient who comes towards the end. And it is very expensive and it gives a lot of hope. It's I've seen patients referred to us from surgical wards with the TPN, and they think that, okay, because it is white colored fluid and the big bags going in, they think that this is going to save the patient's life, and it is damn expensive. So we have to think before where exactly in the illness trajectory the patient is. The patient is having a poor life expectancy towards the end stage of the trajectory. Please don't think about TPN. If the patient is awaiting a corrective surgery and good performance status, then we can consider TPN. So I'll just summarize the points here. uh, Whatever treatment that you plan for patients with bowel obstruction, the first thing to consider where exactly in the illness trajectory they are, on. Are they awaiting a corrective surgery, or are they towards the, as I said, 1 to 3 months of median survival? Where exactly they are standing, and then you ask yourself how aggressively I should address these symptoms. And when it comes to bowel obstruction, all the symptoms can be managed parental methods, parental injections, usually subcutaneous. Most of these drugs can be given subcutaneously or rectally or sublingually. And it is very important to have the conversation with the family, because it is not a pleasant experience to see your loved one vomiting all the time. They won't be able to talk, they won't be able to do anything, and it is very, very unpleasant. So it is very important to talk to the family, and the family, above all this, they want to feed the patient, even if they are vomiting. Oh, they have vomited, so I should feed. So it is very important to have the conversation with the family members. I will just share a story of Miss S. When you always learn theory, right? It is very important to think when we talked about this proximal, distal symptoms, this, that, and all. What was it for that patient? The patient won't understand whether it is proximal, distal, or complete single site or anything. For her, she was in her early 20s. She had a gastrointestinal cancer, very late stage, and she came to us with severe pain in her tummy. For her, it was severe pain. I am unable to sip even water. She was vomiting continuously. She has lost weight. She looked and she felt that I look very bad. So she did not want to meet any of her friends. She could not communicate with her parents because of continuous vomiting. And she was so tired. She was literally bone and skin. The cheekbones, everything was visible, and all the bones in her body was visible. And the parents did not tell her that she has cancer and she is dying. So she did not know what is happening. And she says, I'm unable to go out. I'm losing weight. I'm looking like this. And I don't know why this is happening to me. I don't know the diagnosis. This is what bowel obstruction meant to her. Imagine the life of an early 20-year-old girl with continuous vomiting and all the situation. And for her family, she's too young. How can she die? I mean, she's not old. And we just diagnosed cancer. How can she die? She cannot be dying. We are ready to take her anywhere. But the multiple places, the gastrosurgeons told, no, it cannot be managed. It is beyond surgical management. She lost her weight, she lost her hair, and they lost all their money due to treatment, because they tried everything they can, multiple investigations. And the biggest worry for her mother was that I am unable to feed anything. So I don't want to cook, I don't want to eat. So the whole family stopped eating and drinking because their daughter is not eating and drinking. They all started starving because they don't want to have food when she is starving. So this is the situation of patients and families when they go through the bowel obstruction. So just wanted to, it is always good to remind ourselves that whom we are treating and what is the aim of the whatever knowledge we gained. It is to help people like Miss S to reduce vomiting a little bit. We may not be able to control everything, reduce her pain, so that at least she can talk to her family members and have final conversations before she leaves. At least she is pain free. So these are the things which we should, and counsel the family members, because they stopped eating. That cannot happen, right? She is having an illness, and that's why she's going through this, and we can control that. We can control all the symptoms. So it is preparing the family to leave her peacefully and to have the good time, that whatever time remaining. So I'll stop sharing. That was the last slide. I'm happy to take any questions. If there is anything which needs clarity, I'm happy to explain.
Thank you, Dr. Sreedevi. All of you know, like, see, in fact, you can just discuss this case, what she has brought up. No? From what you have heard, what is that you can think to that 20-year-old you can do, so that in all directions, anyone can unmute and say or type in the chat, whatever is convenient. And as I always say, there's nothing right, wrong, and all. See here, you have to, can you please explain what is air fluid? Okay, Deva, what is air fluid level in obstruction?
Yeah. Ma'am, so when you take the X-ray erect abdomen, when you see
and maybe
the
you can
image,
get that X-ray itself, Sreedevi. You had a lovely picture, no? Go back
yes,
to that.
you can't see that clear picture in your patients though.
No, but if they
But
take,
still, which is a very
if they
good
take
for
erect,
academic purpose. Yeah.
no, if they take
The erect
erect,
one.
you do get Sreedevi. Many times you do get, but they don't take erect. That's the issue there.
Yeah. So here, if you see, you can see the. Sorry, it is not coming to that slide. If you see this slide, you can see these lines. See, it is like fixed lines at multiple levels. So normal bowel loop you will not see like this. If you just check the normal X-ray erect abdomen of a patient without an obstruction, you can see a lot of bowel loops. You will not see whether I don't know whether you are able to see the arrow of the mouse here. You can see there is I put a line also here. You can see multiple levels like a straight line here, here. When you take a normal X-ray without
in
in a
your,
patient,
sorry dear, in your X-ray picture itself, see the top one. The top one they can see as 3 loops. That whatever in your picture itself, that is
yes.
how, see there?
This one.
See, that it'll have the edges. It'll have the edges. See, imagine, if you imagine how the bowel loop is, you can see that like a concave boundaries. In between, you'll have the dark shadow.
Yes.
Okay. So whereas, see the other one, the line is the fluid, that is the level.
This is the level.
And then air above. Does that make sense? See, all these are, those lines are the fluid levels, and then the space, which the gas above the fluid.
You can check the normal bowel
Anyone
X-ray.
can Google and check.
Yes.
Something more. Why that happens? Okay.
So that is because of this obstruction which happens. So when there is an obstruction site, beyond that obstruction site, there will be fluid buildup. And again, there are a lot of air buildup happening because there can be bacteria from the not so like the tube which is blocked. When the tube is not allowing the fluid to pass every time, your wash basin tube will become dirty, right? After a time, there will be a lot of noise, as I said. So there will be entrapment of air and there will be fluid buildup beyond the level of, or on both sides of the obstruction. So this will be shown as multiple air fluid levels when you take. This happens only when they stand up like that. When they lie down, this will not be seen. When they stand up like that, you can see multiple levels because beyond the obstruction, there can be fluid and air buildup, which is happening. Madam, you want to add something?
See, thank you, dear. See, like her very good example was the wash basin. See, when you're putting stuff in the wash basin, you will have some big particles, small particles. So there is some solid also there. But solid means not big chunks. even like, see, you just, as we say, no, when finally the feces is formed, that is hard. But in between, whatever we eat is a mixture. We love food, no? So we have solid, liquid, semi-solid, all varieties. So everything is there. So all our bowel, even after absorption and things, no, some protein absorption happens in different places. So inside the bowel, you will have different types of particles. And this obstruction is happening in one place. Beyond that, it's not going to allow. But above that, it will be a mixture. Solid, liquid, semi-solid, everything is there. And that, as she said, when someone lies down, you think of gravity also. So when someone lies down, the fluid will come down. So there may be some space. So if you take an X-ray like that, air, fluid, everything is like that. So it will not give a clear picture. It is more of physics here. Okay, so when the same person stands up, gravity comes to play. So less dense, more dense, air is less dense, so it comes up. Liquid is more dense, so it comes down. So all these also you have to understand. So that is why you get a fluid air level. See, it's generally in X-rays, or how do you identify the stomach? Gas bubble, we say, no? So like that, you have not only for the stomach is identified in all X-rays as a nice gas bubble. Similarly, all our bubble also will have a gas and a fluid. So when this obstruction is happening, there is more secretion and collection of fluid, and gas also is there. So that time, this basically physical material, what is there, the liquid is there and on top is there. So because it is obstruction which is causing this, it is like it's like clinching the diagnosis, what we say, no? If you see this, like this we would have learned from our year 3 of surgical posting or something. Air under the diaphragm means it shows one thing. Multiple fluid gas level means it is sign of obstruction. So these are all very, very clear, distinct radiographic pictures which will help us with the diagnosis. It's a little bit of physics also and the pathophysiology. You should remember the pathophysiology, what she explained. And in that, what did she say? So much of fluid collection is happening. That is why that wash basin was a good example. At which level? So more fluid, then more collection, more fluid levels you will see. So that is how it is. Hope I have explained and got it. Very good.
Yeah,
Thank
there
you
is a
very much.
question on gentle rectal measures. Now, sometimes when there is a complete obstruction, we give hyacinth butyl bromide, which is an antispasmodic, and the concept is gut paralysis. We are actually paralyzing the gut. So even if you go aggressively with the rectal measures, like you are giving enema every day, you are giving suppositories, that might cause more pain for the patient because you already paralyzed the gut. The gut is not moving, and then you can't expect. Sometimes people give stimulants, which is very painful for the patient because the gut will start try to push the contents out. So we do, there can be a lot of stony hard stool impaction. So you have to be really gentle, not too aggressive about having a bowel opening when the obstruction is complete, because generally when the obstruction is complete, the patient's longevity will be in few hours to days. So we may not be, we have to really sit and think whether you actually want to go aggressively into giving enema every day. We do try, because once you relieve that stony hard stool, it is a great relief for patients. But if it is a complete obstruction and you are giving a gut paralysis regimen, then probably going to intense on relieving constipation may not work. It is always rectal measures, and it has to be gentle, not
No,
too
main
aggressive.
thing, no, perforation. So if you do something, no, you shouldn't cause more harm. As I've been always saying, no, risk benefit ratio. Always keep that in mind for anything and everything. As I keep saying, no, don't think I'm repeating. You use this. Some concepts have to be used in everything. So you hear if someone is in end of life, okay, that end of life can be from few days, weeks to something like that. Even at that point of time, no, already they are in pain. So you try, so see, per rectal examination, then gentle evacuation, those type of things, no, can be tried. And then you see how bad it is. And again, you do something very vigorous and cause perforation and cause more harm means, so that is where you have to see. So gentle measures, here these type of patients, no, may need to be seen daily, or they may, like home visits may have to be frequent. Again, no resources, availability of manpower, everything has a role. And you have to take it case by case. That is more important. And something else is the how to
Maintain nutrition. So the idea is to maintain the hydration. We may not be, if the patient is too dehydrated, then you can think about hydration, or it is about focusing on moisturing the mouth, yeah, having sips of fluid that keep the mouth fresh. And you can always think of continuous subcutaneous infusion so that the patient is not dehydrated. But otherwise, from the nutrition point of view, that may not be encouraged. You cannot feed the patient literally. All you can think is of maintaining the hydration.
Again, that also you will have to decide depending on the goals of care. See, yes, everyone needs, see, food generally we have food as a symbol of love, affection, everything. But you also have to see if someone has like pyloric stenosis. Okay, anything, but before going in, it will come out. Okay, so those situations, in fact, last week also I've seen a patient like that. So, but it depends on how the patient is, what the family is understanding, everyone. That husband also told me exactly what Sreedevi said. Because they are only husband, wife, no children. So he was telling me, she fed me one day also. I've never left the house without food, but now she can't even eat. Because when I was there, she said she will eat because this husband was one mouth in, immediately she brought it out. She's not even swallowing because she's unable to. So she is really like, she's refusing food. That is how I said. So we gave her some dexamethasone. See, you have to deal with the situation depending on the state of the patient. So if nutrition, again, if it is going to be helpful, how you see the condition of the patient, how he or she is, and then decide on nutrition. If nutrition is going to be helpful and correct the condition and help the patient, then you decide. Otherwise, find out how what. Subcutaneous is one option which you can try for 1 or 2 days. And in spite, because the subcutaneous infusion is not going to correct the problem. And sometimes when the body is really shutting down and things, sometimes IV fluids may be more harmful than benefit. We saw this when we dealt about medical ethics, no? So excessive fluid, pulmonary edema, all that can happen. So you have to weigh the pros and cons. What is the goals of care? What stage is that particular patient? If nutrition is going to benefit, then you think of what are the options. Okay, accordingly, because that is what is important, and especially with this obstruction, and if it is going to be complete obstruction and all, you really have to sit and talk with the family, explain to them the condition, and then take things forward from there. So maybe we'll go ahead with the case discussion.
Sure. There is one question on subcutaneous infusion.
Please go ahead.
We can send a few articles for you because we don't have a separate session on subcutaneous infusion.
Yes.
But you will come across subcutaneous infusion more in end-of-life care also. But fluids and most of the medicines used in palliative care can be administered subcutaneously, like your insulin injections, for example. So it is inserted into the subcutaneous tissue. And if it is an infusion, it will get absorbed very slowly. So the patient will be able to tolerate the infusion far better than an IV infusion. And it can be managed at home. So we can give subcutaneous infusion at home. Even if it comes out, it won't bleed because it is not inside a vessel. And the family will be able to manage less chance for infection. You can keep the subcutaneous site at the same site for around 7 to 10 days without any issue. So there is a lot to subcutaneous infusion. We can share a few articles
Some information,
yeah, some
Sreedevi.
of the articles we can
At least
share,
some
like how much
basic
we can give,
information,
etc.
some basic like do's, don'ts, where it
Yes.
can use, what should not be done, something like that we
And
can
it is
share.
very effective. I don't think I've used IV in last 12, 13, maybe once in a while for an antibiotic, but otherwise we don't put in an IV line at all in our patients. Thank you. So we'll move on to case.
Thank you, ma'am. Thank you for your wonderful presentation. Today we have a case presenter, Dr. Shakti Vignesh with us. Over to you, doctor. Doctor, you are not audible.
Is it audible now?
Yeah, yes. Now it is audible.
Good evening. My name is Dr. Shakti Vignesh. I'm a first-year medical oncology resident based from Chennai. Next slide. Today we are going to see a case of a 63 years female. The diagnosis of carcinoma ovary with stage 4 recurrence with bowel obstruction. Next one. Presenting complaints. A case of 63-year-old female, a known case of carcinoma ovary, diagnosed since 2021, underwent initial neoadjuvant chemotherapy followed by primary cytoretic surgery with the disease recurrence after 9 months, which is followed by secondary cytoretic surgery and multiple lines of chemotherapy after that. Now the patient is presenting with progressive stage 4 disease with the following complaints. She had vomiting for 6 days, abdominal pain for 6 days, and constipation for 6 days. The history of presenting illness: the patient had vomiting for 6 days. It was around 4 to 6 episodes per day. It was associated immediately after taking foods and associated with food particles and bile stain. It was not foul smelling and not blood stained. So, and also she had abdominal pain, which is more over the periumbilical region for the past 6 days, which gradually progressively increased in intensity in cramping type, and it was continuous with mild reduction in pain intensity after taking painkillers. She had constipation for the past 6 days. It was not relieved by any medications or bowel edema. Abdominal distension was present for the past 30 days. His flanks were full and gradually increasing in size, associated with incisional hernia. She was not able to take any proper feeds for the past 10 days. She had a feeling of malaise, feeling of lethargy, no nausea, and fever was present. Next slide. On examination, the patient's performance status was PS2. She was conscious, oriented, afebrile, mild pallor was present, bilateral pleura edema was present, and no icterus was present. CVS S1 S2 plus with tachycardia, respiratory, the bilateral R entry was equal, and reduced breath sound was heard in bilateral lower lung fields. In abdomen, it was moderately distended with the incisional hernia present. The flanks are full and tenderness present on mild palpation itself. So no pressure source. Next. Treatment and significant investigations. Only the relevant investigations are stated here. X-ray abdomen erect and CCT abdomen erect abdomen taken showed features suggestive of small bowel obstruction. Other basic investigations showed mild sepsis, like elevation total count 14,500 with predominantly neutrophils 90%, and CRP was 110, sodium was 130, potassium was 3.2, urea was 33, the creatinine was 1.1. The LFT was, liver function was normal with the proteins of 5.2, albumin 3.1, and globulin 2.1. And psychosocial aspects, the patient got effects of taking continuous treatment and frequent hospital visits for the past 3 years for the current ailment. Hence, she, for the present current condition, she deferred treatment till now for the current episode of vomiting and abdominal pain. The patient was currently admitted due to compulsion by her family members only. She is willing to take any injectables and IV fluids for pain palliation and symptoms relief, but she is not willing for any type of surgical procedures and even for therapeutic ascetic therapy. Next. The main concerns: what will be the effective management options for this patient at this stage, keeping in mind her age of 63 years and the performance status of PS2 and presentation. In what ways reassurance can be given to this patient to improve the compliance with the treatment? So summary, 63-year-old female, case of CA ovary with recurrence with stage 4 disease progression with bowel obstruction. she was not willing for any surgical intervention. Discussion points. What will be the effective management options for this patient at this stage? In what ways reassurance can be given to this patient to improve our compliance with the treatment? Physician dilemmas whether to give the treatment as per patient wish or to try to persuade the patient for aggressive treatment approaches for a present condition, or is it right only to give treatment as per the patient's wish? Thank you.
Thank you, Dr. Shakti. You yourself have put a note at the bottom, no?
Yes, ma'am.
So that was what was done. Am I right?
Yes, ma'am. We gave only conservative management. We didn't do any tapping as per patient wish. Patient gradually and she expired up 6 days later in our hospital.
So, do you work in a unit where there is palliative care?
I am working. I am studying, doing my first year PG in Government Rayapet Hospital in Chennai.
Okay. Thank you very much. Sreedevi, you can go ahead and take, or what would you want to do?
I was thinking when Dr. Shakti was presenting, I think we saw exactly what we have been discussing in this session, right? All
Exactly.
the symptoms,
all
the questions from the
when he started with CA ovary, that's what you were explaining in great detail with your percentage. And so go ahead.
So I'm just curious, Dr. Shakti, what was the supportive care or conservative management you have been doing? Is it something different? Then we can also learn. So just curious to know what was the conservative care.
This case came to me when I was in the first month of my posting. At the time, I was very eager to know what other managements can be done at the stage. So patient was also not willing for any invasive, even for IV line initiation also, she was not willing. We don't practice any subcutaneous infusions in our institute currently. Now only today while I learned newly from your classmate. So I was eager to know what else can be done for this patient at this stage, because all other symptoms it can be managed. Somehow we know how to do. But I have seen around 5 or 6 cases like this, presenting like this, mainly gynecological cases. But we were not able to do anything for those cases because they were having ascites also. So they were all contraindicated for surgery also. So only best supportive care was advised. But we were also not able to see their sufferings. Only we were able to see how they are suffering. We were not able to do anything effectively to manage their sufferings at this stage.
We can actually do ascites tapping. I know that this patient was not willing, but generally we sit and explain in small and simple language that why ascites and how this can be give you a lot of relief. And people are worried about the pain. When you tell that I put in a needle and drain all the fluid, it is very scary. So we make sure that we give local anesthetic before putting in the wide bore needle. Make sure we will not shift the patient to ICU, because here it is for palliative tapping, you can say, right? So you don't need to put the patient into a monitor or the ICU. We generally do it. So there are certain places in Kerala where we do ascites tapping at home on a home-based care. So we do it in our outpatient clinic. We don't tell them to do an ultrasound. So I think it is important to communicate. Okay, this procedure. You might have done that, but ascites tapping is one thing which bring in a lot of relief, and especially with CA ovary, it is generally massive ascites. You will get a lot of, and if you are planning to do an ascites tapping, generally we see in hospitals we stop with 1 or 2 liters because that is what the recommendation is, but we should continue till the patient feels relief. Then only there is a point, because the patient has gone through all the trauma of putting this thing, draining and everything. Till the patient finds it a good relief, you continue tapping. It can go up to 6 liters, 7 liters, 9 liters. Then you will be worried about the loss of protein. Then you will be worried about the hypovolemia. The patient is in this stage. See, she died 6 days later. So we know now exactly where she was. We are not worried about her protein loss or loss of albumin or giving albumin at this stage. We're not worried about that, right? This is not the time that we should be thinking about replenishing the protein part. So, ascites tapping might help, but we should not stop with 1 or 2 liters till the patient gets some relief or till the patient says it is uncomfortable. That gives a lot of relief. And the second wonderful, wonderful drug is dexamethasone. The combination of dexamethasone, opioids, and metoclopramide. As metoclopramide generally, if it is a partial obstruction, continuous infusion or intermittent dose. But the moment you start with the first dose of 8 to 16 milligram of dexamethasone, you will see the change. We are not extending the relief for quite a long time, but till they are there, even if it is a few days to weeks, they are generally symptoms.
So in that case, what supportive care were you able to give? So just for information only, we are not judging your service or anything like that. Just for information, I have also worked in your same Roypeta hospital only. So I would just like to know.
Ma'am, at the time, as Madam said, dexamethasone was given, Madam. Then we gave other supportive drugs like pan, emisect. Then metoclopramide was also given, all given as IV or IM only. Then
See, in these situations, don't think, oh, IV was not given. Even IM also will work. Not that it is not going to work. So, and next thing, in so many sessions you've had, first you telling that symptom relief will be done, no? That is the biggest reassurance. Okay, us explaining to them that complete cure, correction may not be possible, but whatever symptom you have, we will give that symptom relief. If you tell that, the satisfaction and thing what they get will be really more than what they are looking for there. Is that because see, with her, especially with this patient whom you have said, she is having one opinion, family is having an opinion, all that is already in the background and happening all the time. So if you're going to tell her that at least her symptoms you're going to take care of, personally she will be a little bit relieved, So that is, so from the session today and you attending these sessions, how would you think you would have managed differently?
Definitely at the time I didn't talk this much to the patient. After attending all this, I myself see a change in attitude towards palliative care of the patients. Nowadays, my first aim is to improve the quality of life only, improve the pain, at what symptoms, first reducing the symptoms, then only I'm aiming to see whether we can give chemotherapy for this patient or what else can be done for this patient nowadays. So at present, I am seeing cases. Recently, also one ascites case came. First, we planned for pigtail insertion for the patient for a continuous drainage of the ascites. Patient, initially, she was having continuous weekly twice or 4 times. She would come to the hospital for ascites tapping. Every time she used to cry while tapping. Now, after pigtail insertion, she was very happy that they themselves can drain themselves whenever in home. Only for they are coming for chemotherapy at present. So she was very happy that she can take control of ascites collection like that. So many ways it's helped, man. First, it's like I am able to see the cancer patient as a patient, not as a patient, but as a life now. First, I am trying to improve the quality of life by what ways I can make them do their routine work without not making to making to restrict themselves due to cancer. I am ensuring that in all ways they are able to do all the work like they were doing before they got cancer, madam.
And very good. Thank you very much. See, it's in this situation, the third question what you put, that one you yourself will be able to answer because you have attended medical ethics. Now you yourself can tell what is that you would give importance there, or how will you take it?
Still, I don't know, madam. What?
Why? So
I think it is a very important question that we should ask ourselves. Like you only said, the intention was to improve the quality of life of patients. So whether the intervention, if it was a surgery, whether it should have improved the quality of life or whether it should have actually not helped. And sometimes it is easier. For example, in bowel obstruction, it is much more easier. You go back to the evidence. It is very clear that surgery is not recommended, stent is not recommended, venting gastrostomy with ascites, you can't do anything. So now, okay, you know that, okay, I didn't do anything. I did not miss anything. That's the one question that you will ask yourself all the time. Did I miss something? So in this case, there are a lot of evidence suggesting that, okay, this was not amenable to any other treatment. And if you're confused, ask yourself, what is my goal of care here? My goal of care is to make the patient comfortable. Am I making the patient comfortable? Ask the patient whether you're comfortable. So then you will know whether you have achieved your goal. Right? So that is what I do personally when you are in a dilemma. Should I be, example for the 20-year-old girl, we thought, okay, they wanted to try everything possible. She's too young. Why don't we try octreotide? So we all went back and started reading the evidence. What is the evidence? What comparing octreotide and dexamethasone? Is there any more benefit? Am I avoiding octreotide because it is expensive? Is it going to really help the patient? Then we went through a lot of literatures. Then we thought, okay, let's have a trial of octreotide. But it did not work. So then I understood I'm not going to harm the patient by introducing a lot of burden in terms of treatment. Again, TPN. Someone asked, "Oh, why are you not giving TPN for such a young patient?" It is not the age that matters. She is sick. She is going to die, and the TPN is not going to help. So that is, yeah. You keep asking this question with every patient that you see, and that is absolutely normal, and that is absolutely humane because when you don't have any empathy, you will not have any doubts whether you have missed something. So that's actually a good sign. And our mission accomplished at least one doctor changed something in their practice. That is the impact that we are looking for while doing all this program. So glad to hear.
Exactly, Sreedevi, and that to a medical oncologist, because the oncology team is the important team. Because see, again, I'm just going to add on to what Dr. Sreedevi has said. Okay, I always tell this, if something can be corrected, correcting the correctable 200%, not even 100%, I will try 200%. At the same time, if it is in a stage where inevitable only will take over, see, that is what your medical knowledge, evidence, all that you do. Don't think that you make sure, if you think that you've missed, go back, read, get material, double check. Now we are in an era where evidence-based. There is evidence-based, go check it. If the evidence base is going to tell 0.5%, the statistical value is less than 0.5, is that what you want to do for the patient? And last one, you put yourself there and see, is this what quality of life will any human being like or think? Then you explain everything to the patient. You don't even have that doubt. You have found all this, okay? Go sit and talk with the patient. Tell them everything. Then the patient takes the decision. So you need not feel bad at all. Why the patient is unable to take the decision? Because nothing is told, nothing can be understood. Even for us in this field, we cannot understand many things. Being in this field, am I an IT expert? No, I don't know. Some maybe little bit of managing, I know. So like that, everyone can't be expert in every field. But once you're there, you go explain to them. Then the patient makes the decision. So you need not be worried. Our job is to explain everything and make sure the patient has understood. Then give them time. They will make the decision and make your life easy. But the overall outlook has to be there. See, nowhere we are not stopping anything. These ideas you have to take clearly. You're not stopping anything. You're not doing anything wrong. You don't want, or we don't want anyone to do anything like that. But understand overall, get a picture. That is important. So as really, really nice. The case was appropriate. So everything really you've done very well explained. And I think this will be an opener for the whole batch also. So surgical, all fields, everyone will, and working together. So once you work together, you will be able to achieve the best. Anything more to add on, Sreedevi, or I'm going to pass it on? I don't think there are any more questions left.
Thank you, ma'am.
Okay, then thank you very much, Dr. Sreedevi, and thank you very much, Dr. Shakti Vignesh also.
Thank you. Thank you.
Thank you, ma'am. Thank you, Dr. Sreedevi, for the wonderful presentation. Hope the participants have got many insights in these sessions today. Thank you, Radha ma'am, for facilitating the whole sessions. And thank you, Dr. Shakti Vignesh, for presenting more appropriate case presentation. Thank you. Thank you all. Let's see you in the next sessions. Bye.
Thank you.